Okay, so we are going to go over chapter 11. And we're going to talk about white blood cells, or or leukocytes as they're called. Okay, and then we're going to talk about lymphoid tissues and get into some of the cancers and stuff like that, the leukemias. Okay, so leukocytes, these are blood cells. They're specifically white blood cells. And all blood cells originate in the bone marrow. So red blood cells, white blood cells, platelets all originate in the bone marrow. And we have different needs for these. So at some points you might need more red blood cells. At some point you might need more lymphocytes. And so we have to have, to do that, the body has to have separate cell lines, okay, to manufacture these. So when you have separate cell lines, you can express a different colony stimulating factor. That's what that's called. And then you're able to produce, let's say, if you need an increase in eosinophils, you can specifically increase the eosinophils without increasing all of the other blood types. Okay, so there are various stem cells with different abilities to produce these lines that we'll look at in the next slide. And so what we're going to try to do is identify the cells and the cell lines, and then understand the role of these stimulating factors. We also want to understand what's going on with deficiencies, and then finally we'll start talking about leukemias and lymphomas. Okay, so if we look at the developmental stages of blood cells, we can see here at the top we start with pluripotent stem cells. Now the pluripotent stem cells, these are the ones that are sometimes called embryonic. They can form a lot of different cell types. Okay, they have some differentiation, but they're relatively undifferentiated. So these are able to produce, so they'll make one copy of themselves, and then they can make one copy of, let's say, these cell lines, the lymphoid stem cells and the myeloid stem cells. So the lymphoid stem cells will then differentiate further to ultimately come down and produce natural killer cells, T cells, and B cells. Okay? Um, Now, so that's the lymphoid stem cell line. The myeloid stem cell line produces the granulocytes and the monocytes. So that's going to produce these blood cells that are the eosinophils, which we've talked about, the neutrophils, basophils, monocytes, which then form macrophages, and that cell line is also responsible for making platelets. So they make the megakaryocyte that makes platelets, and erythrocytes, red blood cells, which we'll talk about both of these at different times. The platelets when we talk about clotting, and then the red blood cells. We'll spend a lecture or a day talking about those as well. Okay, so white blood cells, further categorization. So they can be categorized not only as myeloid or lymphoid, but also as granulocytes or agranulocytes. Okay, so the granulocytes are the neutrophils, eosinophils, basophils, mast cells. Okay, and that's because they have little granules inside the cell that release factors, or they release molecules. Okay, various ones that we've talked about before. The agranulocytes, these include the B cells, T cells, and then this natural killer cell. Natural killer cells are specialized cells that recognize diseased or damaged cells. Specifically, they recognize things like tumors. Okay, so stuff that's trying, maybe things that are so messed up that the cytotoxic T cells can't even recognize them, and so these natural killer cells will just kill anything that doesn't look right. Okay. Now remember, the agranulocytes also include the macrophages. Macrophages are not granulocytes, even though they're myeloid in origin. Okay, so don't mess that up. All right. So the cell line. So if we drill down again and we just look at these two cell lines, focusing on the myeloid and the lymphoid, we can see the same thing. So the pluripotent stem cells can differentiate into these, the myeloid and the lymphoid. And again, the word myeloid comes from bone marrow. Okay, so that's its origin. And so when we say that, it pertains to the bone marrow, even though all blood cells are initially produced in the bone marrow, myeloid cells mature there as well, and we'll talk about that later. Okay, so the lymphoid include the B cells, T cells, and natural killer cells. Okay, and then these cell lines can further differentiate into the actual blood cells like like the eosinophils and the neutrophils and things like that. Okay, so this is just images of these. As you would see them under a microscope, they're easily recognizable, and of course we start to recognize why it's important to know what they look like, um, because when you don't see these um, very recognizable shapes, the shape of their nucleus and things like that, then we sort of know that things are going wrong, and that's how certain neoplasias, dysplasias, things like that are recognized, is because this is what we expect to see. We expect to see them look like this, but then they don't. Okay. All right. So okay, I mentioned this before. Remember, monocytes are agranulocytes. Okay, so they kind of get in that category with the lymphocytes, but they're not lymphocytes. They're myeloid. Okay, the rest of the myeloid line, except monocytes, are granulocytes, and lymphocytes are agranulocytes. Okay, so it's not that tricky if you remember that the monocytes are agranulocytes, and they're really the outliers, the odd ones out, when you're trying to categorize them as lymphoid versus myeloid or granulocyte versus agranulocyte. Okay, so lymphoid cells, we'll start talking about those first. T cells. Okay, so we've been talking about T cells. I don't know if you're aware of this, but T stands for thymus. Okay, so the thymus sits right behind the sternum in the mediastinum. It sits right there behind the sternum. It looks like a butterfly. Okay, it's larger in children. Children are making more T cells. As you get older, you produce fewer T cells, and so it gets smaller and smaller and smaller, especially after puberty. Okay, so the thymus produced the T cells are produced in the bone marrow, but they mature in the thymus. Okay, so that's why they don't have that myeloid designation, if it helps to remember it that way, because this is where they mature. They mature in the thymus. Now they're also called CD4 cells, which are the helper T cells, and CD8 cells, which are cytotoxic T cells. Now we haven't really talked about that. But this is how they're often referred to as CD4 positive or CD8 positive. And the reason for that is because they have these little markers or these little proteins on their surface, and they're not this large, but they have these markers on their surface which are distinguishable. Okay, you can't tell by looking at them, but you can sort of molecularly or antibodies can recognize the difference between these. And so these have different recognition proteins, um, and of course they serve very, very different functions. Okay, so these designations represent specific proteins on their surface membranes. B cells. Now B cells, we can be okay with the B meaning bone marrow. Okay, it's actually from a part of a bird called the Bursa fimbriae, that's where they initially found these, but they found out in humans that they are made, and they mature in the bone marrow. So B works for bone marrow, if that helps you remember it. Okay, so they're produced and mature there. They can become B cells. Remember, B cells are what becomes plasma cells, and plasma cells are the ones that make the antibodies. Okay, so there's a picture of the B cell making antibodies, which now turns into something called a plasma cell. And then the natural killer cell, as I mentioned earlier, they kill tumors as well as other dysfunctional cells, and they're technically considered part of the innate immune system. We haven't really talked about that yet, but that's where they are. But they're still lymphocytes. Okay, um, lymphoid tissue. Since we're talking about lymphocytes, we kind of need to understand a little more about the lymph system, and specifically the lymph tissue. Okay, so we've already talked about how fluid moves from the blood, and then it kind of oozes out of the capillaries into the tissues, and then you kind of have a positive flow into the tissue, so the rest of that is scavenged and brought back into the lymph system, and then it will ultimately make its way back into circulation. Okay, so we have now this can make sense now. We have a couple of different categories. We can either refer to as primary lymph tissue or secondary lymph tissue. Now the primary lymph tissue is going to include the thymus and the bone marrow, and that's because that's where T cells mature in the thymus, and B cells mature in the bone marrow. So that's where they're produced and that's where they mature. And then they move out and they move out into the secondary lymph tissue. And this includes the tonsils, the spleen, and the lymph nodes. And these are usually encapsulated. Okay, so these are structures that have a boundary. Um, and so when if your lymphocytes, your B cells and T cells, after they're produced and after they mature, they move to these areas, then it kind of makes sense why when you have an infection and you're producing more of these, that you would have enlargement of these particular things. You would have enlargement of the tonsils, the spleen, and we've heard about enlarged lymph nodes. All of these things can become enlarged with following an infection or during an infection. Okay, now we also have some other protective lymph tissue. It's called diffuse or mucosa, meaning mucous membrane associated lymphoid tissue or MALTs. Okay, and now what these do is they don't have a capsule, so that's why they're called diffuse, and they kind of guard the respiratory, genitourinary tracts, alimentary canals, anywhere where there are mucous membranes and there's a vulnerability to infection. These guys will collect lymph cells there, and so they have these diffuse structures. Okay, just not enclosed in a capsule. That's the big difference. Okay, so let's look at a lymph node. Highly organized, and so that may be how we're thinking of it differently. We're used to just thinking them as seeing the pictures of them, but now we can actually start to think about how they're different structurally. Okay, so they're highly organized. They have two distinct functions. They filter foreign material. Okay, so all of these bacteria, cell particles, stuff that ends up in your tissue can then move through these lymph vessels. Okay, so you can see here how you have the afferent where it moves in, and then it can just sort of move through here. Okay, and it will be exposed to the B cells and the T cells, and then it will make its way out through the efferent. So it can move in through a number of different places, and then it kind of moves around here. All right. So it's also the center for proliferation and response of immune cells. So we bring those two things together. We have immune cells in here. It's a nice place for them. And then all the bad stuff is brought to it, so to speak. Okay, they can vary in size from 1 millimeter, which is pretty tiny, like maybe it's very, very tiny, um, and up to 2 centimeters, in size, which is almost an inch. So a lot of variability in size. And then of course they can get even larger when during an infection. Okay, they have an outer cortex and an inner medulla. Okay, so that's kind of a theme with a lot of different organs. So outer cortex, which is out here, and then the medulla is usually in the middle when we use those terms. Okay, the B cells and T cells have different homes. So there's the outer follicle area, which is where B cells are, and remember this term follicle because it's going to come up later. So this is a follicle up here, and so you can kind of see how it has um, its own little structure within the lymph nodes, and this is where the B cells tend to hang out. Okay, so this is a secondary follicle, the primary follicle. I'm not too worried about you knowing the difference, but the primary follicle isn't functional yet, so that's still developing, and so the B cells will hang out in this secondary follicle, and then there's this mantle zone. Okay, so the mantle zone, which is kind of on the outer part of the follicle. Okay, so we're looking at the follicle, and then we're saying, okay, well, there's a germinal center, and then there's this mantle zone on the outside. Now this whole thing is associated with B cells, but believe it or not, the B cells are in different stages of their maturity. So you may have some that are memory B cells, and you may have some that are turning into plasma cells, and so those even get distributed differently. Okay, so the cortex around the follicle is the T cell zone. So this is the cortex around here. Okay, so you see the purple follicles, and then around that area are where the T cells are. Now, you do have interaction. The T cells and the B cells have to interact, and they do, and they interact within the lymph nodes. So this is mainly where they primarily are found, but there is interaction. Um, so even though they do interact, a malignancy, okay, like a lymphoma, will localize to these areas depending on whether it's a follicular lymphoma, like B cells, or a T cell lymphoma. And you do see this term, follicular, or you see mantle. Um, uh, the term mantle is used to describe some types of lymphomas, and so that's going to indicate where it is. And it also kind of indicates what type it is. Okay, so white blood cell disorders, we can characterize these as non-neoplastic, which means not cancerous, and neoplastic, which we generally consider being cancerous. Okay, non-neoplastic could include an increase, although normally when you have an increase, you're talking about a cancer. Or a decrease, and we're going to talk about some of the decreases. So an increase would be called leukocytosis, a decrease would be called leukopenia, and this name, penia and cytosis, just sort of remember that as being increase for cytosis or decrease for penia in the number of white blood cells. So leukopenia, um, and then we have neutropenia, which is talking about neutrophils, okay, specifically. So this, I guess that would be a suffix, penia, refers to lower or fewer. Okay, and then we can go so far as being agranulocytosis, and the A means none or absent. Um, so aplastic anemia, infectious mononucleosis, which we'll talk about that, and then HIV are also um, can also cause a decrease in, like your specifically if you've uh, been paying attention to some of the research, CD4 positive cells. Okay? So CD4 positive cells are decreased with HIV, and that's part of the problem. Okay, um, let's see. And then the neoplasms. So neoplastic white blood cell disorders could be leukemia, so we'll talk about that, and then lymphoma. So I think many of us have heard leukemia, lymphoma, and we know it's not good, and we maybe even know that it's some kind of blood cancer, but we need to get into the details of exactly what they are. And then plasma cell dyscrasia, you may never have heard of that, but you may have, I shouldn't say probably, you may have heard of something called multiple myeloma. I think somebody who I should probably know who it is, but I think an athlete or something was just diagnosed with multiple myeloma. It was on the news and they were talking about it as though everybody knows what multiple myeloma is. Well, good news, you're going to. All right, so the non-neoplastics, we'll start with that first. The normal total white blood cell count, 4,500 to 10,500. Okay, so you need to know this number. Um, so about 5,000 to 10,000, but 500 on both sides. So 4,500 to 10,500, 5,000 to 10,000, right. So leukopenia, we've already mentioned that, a decrease in the white blood cell count. And so even though leukopenia, leuko refers to white, so the white blood cells, even though that includes all white blood cells, remember the most prevalent white blood cell are neutrophils, and so the neutrophil count is usually what is causing a lot of the problems when you have a lower white blood cell count, but not extensively. But it's a nice way to look to see if there's any kind of a problem. Okay, neutropenia, that again we had that in the previous slide, refers to neutrophils. Okay, so neutropenia refers to neutrophils. So if the neutrophil levels are less than 1,500, then we consider that neutropenia. Okay, now it can be, you can have mild, moderate, or severe, and those all have their own numbers. I'm not too worried about that. But it's specific, neutropenia is specific to neutrophils being less than 1,500 per microliter. So that's 1,500 cells. It's actually talking about the cells. Now, if you get to less than 200, then we say pretty much, yeah, you're gone. They're absent. You don't have neutrophils. Yeah, you might have some, but 200 is not enough to get the job done. So that's what we refer to as agranulocytosis. Okay? Agranulocytosis is the virtual absence of neutrophils. Okay? It's a neutrophil count of less than 200 per microliter. So you can also have white blood cell deficiency or disorders from So you can have it where they're absent completely, or you can have it where the where their production this can be caused from well, okay, they're all from. So what we're talking about here is all deficiency, but it can be from not producing enough, so reduced or ineffective production, or it could be from excessive removal. Okay, so they're going away for whatever reason. So inflammation may be a cause of that. Okay, so it could be congenital. So I mean, what might cause your white blood cells to disappear? Maybe congenital or to have low. Pathology induced, so we know some pathologies like HIV that can reduce those. Or it could be drug induced. So agranulocytosis is a common side effect of drugs. Um, so any of these things can result in lower white blood cell counts. Um, and there's a lot of pathology that involves that too. Okay, so white blood cell deficiencies increase the risk of infection. Well, that sort of makes sense. We're talking about white blood cells. We're talking about our immune cells. So if you don't have enough of your immune cells, then you're going to increase and open yourself up for infection. And a lot of times those infections are respiratory. Okay, so, so our body is constantly fighting stuff off. The lungs are a great place for bacteria, viruses to take hold. And so if you don't have the immune cells, then that's going to increase. So what happens if you don't have or if you have a decreased or deficiency in white blood cells is that common infections could become fatal. A lot of times things like fungal infections, which normally the body fights those off fairly easily. In someone with a white blood cell deficiency, these can actually become fatal. They can really take a hold. So any kind of virus, bacteria, anything like that can really take hold and can be fatal. Now I have this question down here. Would you expect to see pus? Let's say with agranulocytosis, would you expect to see pus? Well, since one of the contributors, the main contributor to pus is neutrophils. If you're not making neutrophils, then you could have a small skin cutaneous infection and you would not see that marker. You would not see pus. Okay. All right, so let's first of all talk about this again. We're still in the category of non-neoplastic, so non-cancerous white blood cell disorders. Um, Infectious mononucleosis. Okay, so I think most of us may have come across the term mononucleosis. Usually people just call it mono. Hey, I've got mono. Well, stay away from me then. No, just kidding. Not really. So, but mononucleosis is pretty infectious. This type is. So it's most prevalent in teenagers and young adults, and it is caused by, and you need to know this, the Epstein-Barr virus. The Epstein-Barr virus is in the family of the herpes virus, so it's different than oral or genital herpes, but it's in the same. The virus is very similar. It's in the same family, so it's so that's what that means. Um, so this virus that causes mononucleosis has this really cool, or the Epstein-Barr virus, has this really cool way of evading the immune system. And this can be problematic, but we've pretty much learned to live with it because 90% of us, by the time we're 40 or something like that, have been infected by the Epstein-Barr virus. Okay? And there are reasons for that. So 90% of humans, and it persists for life. So once you're infected, it kind of just sits in there and stays. It's just sort of part of you now. Your immune system keeps it quiet, but it's still kind of moving around in there. It spreads through oral secretions, which is why mono or mononucleosis is often called the kissing disease. It's spread through saliva primarily. Okay, and this is another important thing that you have to remember. Mononucleosis infects B cells. Okay, so you're going to notice the pattern that B cells are taking a lot of hits with a lot of these diseases. Okay, so a lot of them affect B cells, but mono's no exception. Infects B cells, it may kill them, which means that the virus moves into the B cell and then it multiplies and then it pushes out and spreads its virions all over and then can infect another cell. Okay, and that just sort of continues. Another thing and that's usually when you're actually feeling the signs and symptoms, is when these are being when it's very active. Okay, so another thing that it does, and this is why it's in 90% of us pretty much, is that it can upload itself. So the Epstein-Barr virus DNA can upload itself into the genome of the B cell to form something called a heterophil. Hetero means different, and that means that it has DNA from different sources. And now this cell uh, can survive and but it will produce markers on the outside of the cell that the immune system can recognize. And so you can tell if someone has been infected by Epstein-Barr because they will have these markers or these antibody markers. Okay, and so but it's not enough to get rid of it. So and this is why it can become dormant. Okay, so this Epstein-Barr virus can get into the B cells, upload itself into the DNA, and become dormant and not really do anything. But it can continue to proliferate at very, very low levels. So every now and then it might throw off some viruses, um, and then but by that time your immune system is already on it, already looking for it, even though it's hiding. And so if you're healthy and you have a healthy immune system, then you should be able to keep it down. However, the fact that it's still there means that it can still be transmissible. Even if you're asymptomatic, even if you never even knew you had it, you can still spread it. And that again goes back to 90% of people are infected. So you may have been infected by someone who didn't know they were infected. Okay? And as long as your immune system is healthy, it's not going to make any difference. Okay, so onset is gradual, may have a 4 to 8 week incubation period. That's a long time. Okay, that's a long incubation period, and you can be um, infectious even before symptoms develop. So 4 to 8 week incubation period before the symptoms develop, and then these symptoms tend to be fever, severe pharyngitis. Okay, so this inflammation of your throat, so basically a sore throat, and this is what gets a lot of people in to see a practitioner, is that they have this fever, they have the sore throat, and but it also has inflamed, which means sore, painful, swollen lymph nodes. Okay, so your lymph nodes are not just swollen, but they're inflamed, they're sore, you feel pain when you touch them. I'm making a big deal about this because the lymphomas, which are cancer, are not painful. You still have swollen lymph nodes, but it doesn't hurt. There's no pain. They're just swollen. Okay, so we call that lymphadenopathy, the swollen lymph nodes. You may have an enlarged spleen. That's a little bit harder to see, splenomegaly. But the large spleen, again, you're talking about B cells, you're talking about a lymph organ, and so that also is going to cause cause an enlargement. Now you may be saying, well, if it's killing B cells, why are the lymph nodes in the spleen enlarging? And that's because cytotoxic T cells can kill infected B cells. So you do launch an immune response against it. Okay, but your T cells then start, taking out their brother, the B cell, to try to get rid of it. So the cytotoxic, these CD4 positive cells can recognize, and of course that's because partially because of this marker, but they can recognize and they can kill infected B cells. Now, I shouldn't comment too much on that marker because when the virus is active inside the B cells, the CD4 cells will just see it anyway. Okay, so they'll just recognize it uh, as an infected cell, and they can recognize it in that way too. Okay, so can kill infected B cells to control the virus as long as a person is otherwise healthy. So what that means is that any kind of treatment is going to be symptomatic and supportive. Basically, all you do is you say you a lot of times people are hospitalized with this because their immune system isn't working properly, and so you put them there, you observe them, and you make sure that their symptoms aren't becoming life-threatening. And in which case, then you can probably do some antibody types of treatments, but generally it doesn't come to that. Generally, the person's immune system will kick in. These CD4 cells will ultimately knock the Epstein-Barr virus down well enough to control it. And I have this little FYI over here. It's called mononucleosis. It's a very confusing name. Because if you break this down, mononucleosis basically means one nucleus. But it looked like monocytes when they first discovered it. They thought the B cells kind of gave the appearance of monocytes, and so they called it mononucleosis, and that's now the name we're stuck with. Okay. All right. So that was an example of a non-neoplastic disorder and some explanations of what non-neoplastic disorders are. Now we're going to start talking about the neoplastic disorders, and we're going to spend a little bit more time on that. Because these are the most important blood cell disorders, because we're talking about cancer. Okay, so two origins. Again, we go back to our cell lines, the myeloid. Okay, the myeloid, remember the granulocytes and myocytes. Okay, so if they're from the myeloid line, and remember the myeloids are formed and differentiated in the bone marrow. And then the lymphoid. Okay, so the lymphoid are from the lymphoid cell line. These are white blood cells that travel to the lymph organs to mature and develop. Okay, now the B cells will develop in the bone marrow as well, but they go to and they hang out in lymph nodes as well, as we've already seen when we were looking at the lymph nodes, okay, and the follicles. Okay, so when we're talking about leukemias, the leukemias will include lymphomas, but lymphomas are solid tumors that affect the T cells and the B cells. Lymphomas are solid tumors, and those are Hodgkin and non-Hodgkin. So we're gonna talk about all of these things. I don't mean to say too much about it or confuse you, but we're gonna talk about each of these individually. So the etiology of these neoplastic disorders, these cancers, largely unknown. Okay, so some people can get it without having any risk factors or knowing why they're getting it at all. Radiation, we know that radiation causes that, including radiation that's used to treat cancer. Toxins can cause it, benzene, formaldehyde, family history, so that contributes, and certain congenital disorders can contribute too. So all of these things are contributors, but ultimately, in some cases, you just don't know the reason. Okay, so leukemia. Leukemia, the definition means white blood. Okay, so that's what leuko, and then the emia refers to the blood, I guess. So leukemia means white blood, indicating the increase in the number of white blood cells in the blood. Okay, so when the person was looking at this that originally discovered it, they noticed that there seemed to be kind of a switch. There were more white blood cells than red blood cells, so they called it white blood and named it leukemia. Okay, which is a fine name. Okay, so malignant neoplasms, this is what a leukemia is. It's a malignant neoplasm of cells derived from either the myeloid or the lymphoid tissue. Okay, so the malignant cell type will overtake other cell types, and this is a very, very important statement right here. So when you have cells, a certain cell line or a certain cell that is being overproduced, what that will do is feedback will cause less production of other cell types. Okay, so your blood doesn't just become syrup. You actually just simply produce less or fewer of the other blood cell types. Okay, so the malignant cell type will overtake other cell types, including red and white blood cells, leading to increased risk of infection from white blood cells and anemia from red blood cells. Anemia is just the presence of red blood cells, and that's the oxygen carrying capacity. So that means your cells aren't going to work as well. You're not going to have as much oxygen, those kinds of things. So this can be a real problem. There are four types of leukemia. There's the myeloid. They can be the myeloid or the lymphoid in origin, and it can be chronic or it can be acute. So a mix of these, myeloid, acute or chronic, lymphoid, acute or chronic, comes to four different types. Now there are different specific cells that are affected, or the presentation of these can be different. Like there's hairy cell type, and that's only because the cancer cell looks like it has little hairs on it. So there are a lot of different, I guess you could call them subcategories within these, but they will all different leukemias will fall into one of these four categories. Okay, so we've already talked about myeloid versus lymphoid, so now let's talk about acute versus chronic. Okay, and then we'll put them all together. So the difference between acute and chronic, and this is important. Acute is going to be a rapid onset. That's kind of the definition of acute. Okay, that means it comes on fast and it progresses. Okay, rapid onset, rapid progression, both of these things. Okay. Um, the other thing is that you have a high blast count. So this term blast, I know we've seen it with fibroblast, um, blastoma. So you see blast cell, and that's kind of an originating cell. It's an immature cell type that's going to then produce something else. That's what blast means. You see it all over in biology. And so it's no different here, a high blast count. So they're immature, undeveloped cells. Okay, and these, of course, then will replace the normal cells. So you ultimately have, so it's kind of a it's kind of strange. You have an increase in production, and yet they're non-functional, and so they replace the normal functional cells. Okay, depressed bone marrow function can infiltrate various organs. Okay, so moving around in that way. Um, so anemia can be a sign symptom. Easy bruising is a symptom. By the way, the difference between signs and symptoms is a sign you can read a sign, that's something that can be measured. A symptom is something that can be described but not necessarily measured, in case you weren't aware of that. So anemia, easy bruising, weight loss due to hypermetabolism. So now we have this overproduction of a certain neoplastic cell and so you have increased activity, and so this increased activity requires um, ATP, and so we call that hypermetabolism, which means that it's sapping energy from other functions, other cell functions in the body. Okay, bleeding due to low platelets, because remember, you're replacing other cells, other cell types. And so your platelet count will fall, which can increase bleeding. Bone pain due to marrow expansion. So you have overactivity of the bone marrow. So even though the bone marrow, the functionality is less in terms of producing normal cells, you still have the overactivity and you have the expansion. And that's going to push out on the bones. It's going to cause bone pain. All right, so chronic insidious, which means slow onset, it tends to be prolonged. And the proliferation is different in this way too, in that it's more differentiated cells. Remember, with the acute, we had the blast cells. With chronic, we have more differentiated cells, and they can be, of course, myeloid or lymphoid. So in fact, chronic a lot of times is discovered during other tests. People may be asymptomatic; they may not even know that they have it. And so in some cases, not all, most of the time you want to get rid of this, but in some cases you may decide that you want to withhold treatment, or the patient may decide that they want to withhold treatment until symptoms develop. Okay, so that may especially be the case in some older patients where the treatment may do more harm than good. Okay, so if we look at all of these, and I made this table here so these are all four of the categories, and I put some things in here, not all of which you have to know, but some of it is just kind of good to know. I tried to underline what I want you to know, except down here I forgot to underline the Philadelphia chromosome, but we have a whole slide on it, so you'll hopefully get that. But I'll just go through these quickly. Acute lymphocytic leukemia, ALL. This is the one that is most common in children. Okay, so 75% of new childhood cases are this acute lymphocytic leukemia. Now, the thing about acute leukemias, and I forgot to mention this before, is that if you have a fast onset, you're getting to the hospital quickly. Okay, you're going to seek treatment very, very quickly. So you get treatment quickly for the acute, and these are the ones that suddenly come on with children. Okay, so it's less common in adults, but it does happen in adults. So it's only 10% of all leukemias, but this is the one most of the time, and that's where we tend to think about leukemia in a lot of ways. You know, the poster child for leukemia kind of thing, uh, because it can be very, very devastating to the families. Not to mention the children that are affected by it. Okay, so even though it's 10%, this is the problem. Is it's 75% of new childhood cases. Now, if we move over here, so this is lymphoid, so acute lymphocytic. So this is lymphocytic. If we move over here to the other acute leukemia, myelocytic. Okay. Now, this one is 45% of all leukemias. So this is this is the most common leukemia. But it's most common, uh, it's mainly in older adults. Okay, now it still is getting the rest. So both of these acute leukemias are affecting children. So the remaining 25% of children. Now you'll see some scattered cases of the chronic leukemias in children, but they're much less common as these acute. Okay, so second most common leukemia in children, but it's the most common overall, and it mainly affects adults. And this of course, inhibition of myeloid cell differentiation, so immature blast cells, okay, because it's acute, again, replace normal cells. Now, if we move down here to the chronic, we can see here chronic lymphocytic leukemia, CLL, and most of the time you'll just see these abbreviations, CLL. That's about a third of all leukemias. Okay, so it's out there. But again, this is mainly in adults, and specifically, this is mainly in older adults. Okay, so a lot of these are true. If we look at even the AML, the acute myelocytic leukemia, um, that also is mainly in older adults. This is mainly in older adults. And if you look at this other acute, the average diagnosis age is, or the chronic myelocytic, the CML, the average age of diagnosis is 67 years old. Okay, so this is older people, especially with the chronic, older people that are going in for different tests that discover that they have a white blood cell count that is off. Okay, and a lot of times that turns out to be one of these leukemias. Okay, um, so CLL, rare in people younger than 40, and there appear to be two forms of the CLL. They can be either highly aggressive or slow progressing, and the slow progressing is the one that a lot of times just isn't treated. Now, this last one, chronic myelocytic leukemia, it's not very common. It's only 10 to 15% of all leukemias. However, um, one thing that you'll probably see again, not just on my exams, but maybe on the NCLEX, is this presence of the Philadelphia chromosome. Okay, so the Philadelphia chromosome is associated with CML. Okay, so however you want to remember that. Um, I know a lot of you picture your notes, so you'll probably remember it in that way. The myelocytic was on the right, and the chronic was on the bottom, and the Philadelphia chromosome was on the bottom right. But however you can remember that because it's called the Philadelphia chromosome because the researchers who discovered it, it was discovered in two different hospitals that did the research on it, and they were both in Philadelphia. So they call it the Philadelphia chromosome. 95% of people with CML have this altered chromosome. We'll look at that on the next slide. Okay, so granulocytes and megakaryocytes, which make platelets, that's what's affected in CML primarily. Again, 10 to 15%, and average age of diagnosis again is up there. It's 67 years. So let's look again at the Philadelphia chromosome. And you don't have to know all of these details. What you need to know is that there are two separate chromosomes from two separate, so I was going to say from two separate areas, but they're both in the nucleus, but they're two separate chromosomes, and they hybridize, so a gene on them hybridizes to move to produce a specific chromosome on chromosome or a specific gene on chromosome 9. And so any chromosome that has this, whoops, any chromosome that has this change is considered the Philadelphia chromosome. Okay, so again, it's CML, chronic myelocytic leukemia. It's rearrangement of this BCR gene and the ABL gene. And 95% of people with CML um, have the mutation. Okay, so that's carefully worded. It doesn't mean that 95% of the people with the mutation will get CML. I don't know that that's actually known. But when you look at people with CML, 95% of them have the mutation. Okay, so that's your indicator right there. Results in formation of the Philadelphia chromosome, which is discovered in Philadelphia. Now, this is what's interesting. How it works is not yet known. We don't know how it works. But we do know that one of the genes, this ABL gene, is involved in regulating cell division, which means that it's an oncogene or a proto-oncogene if you don't have cancer. But that's what the ABL gene is. It's something that's involved in cell proliferation, division. So we call those oncogenes, and sure enough, it seems to be playing a role in this Philadelphia chromosome. Okay, so those are the cancers. So mainly just knowing the difference between the acute versus chronic, some of the details that I mentioned. The blasts, those kinds of things, all the stuff I mentioned, that's important. Now we're going to talk about lymphomas. Okay, so lymphomas. Lymphomas are solid tumors. Okay, solid tumors of neoplastic lymphoid tissue. So now we're talking about cancer solid tumors developing in the lymph nodes. Okay, so they may vary with respect to molecular features, presentation, and treatment, and these are the most curable form. Okay, so this is the most curable human tumor. So if you're going to get something, get a lymphoma, I guess. Classified as non-Hodgkin or Hodgkin. Okay, so we're going to talk about 3 different things that distinguish Hodgkin from non-Hodgkins, and I can just go ahead and say it. First of all, non-Hodgkin is B cell and T cell. There's the presence of the, well, I'll just go through them. The non-Hodgkins can be T cell or B cell, while the Hodgkin is only affects B cells. The way that they spread, the Hodgkin has a much more recognizable and predictable way of spreading, so we'll talk about that. And the Hodgkin have these things called Reed-Sternberg cells. Okay, so those are really the 3 distinguishing things between these two. Okay, B cells and T cells for non-Hodgkin, and this is much more predictable and has the Hodgkin is much more predictable in its spread, and it has the Reed-Sternberg cells. Okay, so let's first of all talk about non-Hodgkin. Heterogeneous, it varies widely. It's most commonly in lymphoid cells with B cell differentiation. So 85%. So even though it can affect B cells or T cells, 85% of them originate from B cells. It is one of the, so non-Hodgkin lymphoma is one of the most common cancers. So it's 4% of all cancers. Okay, which the bleak meaning of that is that there's a 1 in 50 chance of getting non-Hodgkin lymphoma. Okay? It's 3 times more common than Hodgkin. Okay? And the unfortunate thing is that Hodgkin is actually more easy to treat than the non-Hodgkin. So the non-Hodgkin is 3 times more common, and unfortunately it's less able to be treated. Still very treatable though. Okay, so risk factors, a lot of it's we don't know, but the risk factors depend on the subtype, the gender, the ethnicity, chemical or radiation exposure, immune dysfunction. So a lot of things may contribute, and it really depends on the specific, I guess, subcategory or subtype of the non-Hodgkin lymphoma. Okay, so possible pathogenic origins. Epstein-Barr virus. There we go again. So that doesn't look very good in terms of since 90% of us are infected with the Epstein-Barr virus. But this is seen in some populations in Africa, and a lot of times it's associated with a with malaria as well. So there are contributions by viruses. It's just a matter of trying to figure out exactly what they are and how those work. So Epstein-Barr virus, human T cell lymphotrophic virus or HTLV1, HIV. Okay, so we see this more with HIV, and even H. pylori bacteria, which is the cause of ulcers in the GI tract or in the stomach. Okay, so we're talking about, so if we look at specifically some of the B cell lymphomas associated with non-Hodgkin, we can see that they're named, well, some of them are named in ways that kind of make sense. Follicular, okay, so remember those follicles. 21% of all non-Hodgkin lymphomas, uh, and that's are follicular. 31% are these large B cell. Okay, so now these can be very aggressive. Okay, and they're not as easy. They're not necessarily. They may be nodal, so they may be as part of the lymph nodes, or they may be internodal, so they may appear between the lymph nodes. Which is still, reasonably easy to find. It has a 60 to 80% remission rate. Okay, so that's large B cell. Burkitt lymphoma. These are rapidly growing, and these also may be virally related. So that's some of the research they've done with this in the Epstein-Barr virus. But these have a 90% cure rate. Okay, so that's actually very, very good, because we're not talking just about remission. We're actually talking about cure rate. Mantle cell, so that also leads us back to the lymph node. Less than 10%, rapid progression, less than, and these are not so good, less than 1 in 5 survive past 5 years. Okay. All right, so that's not very good, but fortunately it's not as common either. And then marginal zone. That's what I meant. Marginal zone, found that's the one that leads us back to the lymph nodes. Found in the marginal zone of the lymph nodes, and that involves the memory B cells, which we really haven't talked about yet. But that's another. When you have an infection, a lot of your plasma cells will become or a lot of the B cells that recognize the pathogen will become memory cells. They can be activated later. And even those can become malignant. All right. So so we're still talking about non-Hodgkin lymphoma. So we continue that manifestation. Okay. So the most frequent manifestation is this painless lymphadenopathy. Okay. So that's the swollen lymph nodes. It's isolated. It may be isolated or widespread. So I was kind of alluding to this earlier when I said that's one of the differences between Hodgkin and non-Hodgkin, is that the non-Hodgkin doesn't always progress in a predictable fashion. Okay, so like Hodgkin does. So where it may go from node to node, and it may progress very predictably in Hodgkin, this one may be found in the mesentery, retroperitoneal, often involves bone marrow, so that can sometimes happen. Usually that's in someone who is immunocompromised, but it's a little less predictable. Okay, so it can be isolated or it can be widespread. Now, some of the manifestations with more intermediate or aggressive forms may include unexplained fever, night sweats, fatigue, unexplained weight loss, and also you can see reddened patches on the skin, which can be from the fact that it's interfering with the production of other types of blood cells. Okay, so diagnosed with lymph nodes. So when we look at this, we have to actually take a biopsy. So we have to actually cut a piece of the lymph node out and then actually look at it, and we look at these surface markers. So some of these proteins that are on the outer surface. That's how we identify it. Okay, so now we're moving on from non-Hodgkin to Hodgkin, and the big thing is the Reed-Sternberg cells. Okay, so these guys, who they're named after, discovered and categorized this and figured out that if you saw this cell type down here, the Reed-Sternberg cells, that was absolutely a positive marker for Hodgkin lymphoma. Okay, so that doesn't mean that that if you don't see it, that it can't be Hodgkin, but if you see this cell, you absolutely know that it's Hodgkin lymphoma. This is the other characteristic. It arises in a single node or a chain of nodes and spreads first to the anatomically contiguous node. Okay, so that makes it a little easier to keep an eye on and a little easier to trace. So you know that if you found one and then you go to the second and you find it there as well, and then you go to the third and it's not there, I don't want to say you can stop looking, but that's essentially what this means, is that it kind of moves from node to node. And remember, the non-Hodgkin did not. Um, it was not as isolated. It was a lot more widespread. Okay, so it affects it's kind of bimodal. So by that I mean, bimodal curve looks something like that. It affects the 15 to 40 age range and the 55 plus age range, but it's not so much found in the 40 to 55 age range. So if you make it to 40, you're okay until you turn 55, for the most part. Okay, when it comes to Hodgkin lymphoma. But Hodgkin lymphoma tends to be easier to treat, so keep that in mind too. Okay, so manifestations: painless lymphadenopathy, and this is another difference. It's usually above the diaphragm. Okay, so the lymph nodes that it affects are usually above the diaphragm. Sometimes in older men, it can be found in the groin area, but generally it's above that. Okay, so other symptoms are similar to non-Hodgkin, but the Hodgkin may include chest pain from mediastinum masses. So you may get masses in the chest area that may cause pressure and cause chest pain. Okay, so this is the last thing. So those were the lymphomas. So now we're going to talk about specifically, really, what we're talking about is multiple myeloma. Okay. It's categorized under a plasma cell dyscrasia or an unusual event. Okay, this is when we talk about this, we're not necessarily talking about plasma cells yet, but what happens with B cells is they produce specific antibodies. Okay, I should draw that so it actually looks like an antibody. So they produce specific antibodies, and this antibody will then, if it latches onto a bacteria or a pathogen or something like that, then this will go on to clone itself. Okay, because if it recognized one pathogen, then that means that this pathogen exists. And so as soon as it recognizes a pathogen, it goes on and it will clone itself, and it will make another with the exact same antibody, okay, or a B cell receptor, as it's sometimes called. Now, what happens with multiple myeloma or these dyscrasias is that this will start to divide sort of out of control. It just doesn't know when to quit. And so it will keep dividing, and proliferating. And so it involves that single clone, though. Okay, so that's what this means. A single clone of an antibody producing plasma cell. Okay, so remember, the plasma cells are the ones that are producing these antibodies and putting them out there. Okay, so the B cell will turn into these plasma cells, and then you have, what do you have? You have overproduction of antibody. Okay, but it's a very specific one. It's very specific. So multiple myeloma is by far and away the most common. It's actually 1% of all cancers, this multiple myeloma. The proliferation happens in the bone marrow. Okay, so these plasma cells, they go out to the lymph nodes, and that's where they're exposed to the pathogens. But then they will migrate back to the bone marrow as plasma cells, and they will stay in the bone marrow, and that's where they a lot of times will have their effect. Okay, so that's where they're sort of kicking out that antibody, that poorly drawn antibody there. Okay, so I hope that makes sense. The plasma cells are moving back to the bone marrow, and that can cause bone pain. Okay, so now you have the proliferation of a specific clone of these antibody-producing plasma cells. So the B cells turn into plasma cells, and so you have increased bone marrow, more bone marrow, and you have an increase in bone pain. So in fact, it can be so bad that you have these osteolytic bone lesions throughout the skeletal system. So these may show up, these lesions may actually show up in like skull bones or something like that. Because another thing that it does is it activates osteoclasts. Okay, so I don't know if you remember your osteoblasts and osteoclasts, but if you think about blasts as being developing, then blasts are causing bone to form. Clasts are actually sending out calcium. It's actually breaking down. It's actually breaking down bone. Okay. So it increases bone reabsorption, which is going to weaken the bones. Okay, so which can also lead to this osteolytic or this these you can't call them fractures, but these lesions in bone. Okay, which can also cause soreness. Now, the other thing is we're talking about antibodies being produced. Okay, so there are a lot of interesting things about this. You're talking about antibodies being produced. Well, if you're producing antibodies and you have a malignant clonal expansion of a particular um, plasma cell, then you're going to have a whole lot of antibody, of that particular antibody. Now, obviously, the disease or whatever triggered that antibody production is long gone. It's not, it doesn't stand a chance at this point, but you still have the production of the antibodies. And so, what a lot of times you see this in urine. Okay, so you see the increase in urine, which is proteinuria, and normal function of the bone marrow, just like in every other case, is affected. So it decreases the production of other types of blood cells. Now, so a couple of things can happen. So if you're trying to figure out, is this a multiple myeloma, or let's say there's a test question that mentions that there's an increase in calcium. Blood calcium levels are elevated. There's bone pain and calcium levels are elevated. If we're talking about cancer, then good chance that we're talking about a multiple myeloma because the osteoclasts are causing bone to be broken down, which is releasing calcium into the blood, and then of course the bone pain. Okay, so here are some other um, issues. I think we covered most of these. We didn't cover renal failure, but most of these are covered. So I think that's it for this section. I think the rest are the questions that I'll let you work through, and I put some answers on there. So there we go.